Please start, sir. We are live.
Good evening, all distinguished delegates and today's eminent faculty, Dr. Rahul Patil, sir. Yes, from Zydus Life Sciences, I would like to welcome all the delegates and today's faculty for this scientific session called as CLEARTalk. Talking about giving a brief introduction about CLEARTalk. CLEARTalk is one more facet of Unite Against Dyslipidemia, and the recent development in the field of management of dyslipidemia is bempedoic acid, and lately presented clear outcomes trial in ACC, American College of Cardiology 2023. We have one of the best faculty to talk about bempedoic acid through the lenses of clear outcomes trial. So I would like to, it's my honor and privilege to welcome Dr. Rahul Patil, sir. Sir is Associate Professor of Department of Cardiology and Head of Premature Coronary Artery Disease Division at Sri Jayadeva Institute of Cardiovascular Sciences and Research Center, Bangalore. Sir has over 1,500 cath lab procedures, 500 angioplasties, diagnostic angiograms, cath studies, etc., pacemaker insertions. Sir is also specialized in heart attack in younger age groups under 50. A largest follow-up clinic of 2,000 patients for PCAD in the world, and that is something to reckon with. Sir has extensively studied causes of heart failure, heart attack in young patients. Sir has many publications to his credit in national and international journals as a principal investigator. Sir has presentations at various forums. One such example is lipid profile of coronary artery disease in young patients, especially less than 30 years, in South Asian Indians in World Congress of Cardiology. Sir has many awards to his credit. One such notable award is National CSI Conference. He was awarded with best presentation. So we have one of the best faculty, and to speak about bempedoic acid through the lenses of clear outcomes trial, I would like to hand over session to Dr. Rahul Patil. Thank you so much, sir.
Thank you. Thanks a lot. Yeah, I'll just share my screen. Yeah, is this visible?
Yes, sir.
Yeah. So good evening, everyone. I'm Dr. Rahul Patil. I'm Associate Professor of Cardiology from Jayadeva Institute of Cardiovascular Sciences, Bangalore. So today we are here to talk about this newly late-breaking trial which has come across. That is the bempedoic acid through the lens of clear outcomes trial is what we are stressing upon today. So a lot of previous studies have already shown us that there is a significant cardiovascular events reduction for each millimole per liter reduction of LDL cholesterol. Basically, 1 millimole per liter is around 38 milligram per deciliter of LDL cholesterol. So for each such reduction in LDL, there is we have observed significant cardiovascular benefits, and it has been observed that this benefit is more in people who have multiple comorbidities. That is, the more the comorbidities, the more is the benefit of reducing LDL cholesterol. So what are the challenges we are facing when we're talking about treating dyslipidemia with statins, especially in Indian scenario? One is, do all statin users achieve the LDL-C goals? That is the first point. Do we really achieve the LDL cholesterol goals? Second point is, in case we have achieved the maximally tolerated dose of statins and still we have not achieved the LDL target. So what do we do? So these are two important questions. Next, when we go through many of the trials of these newer lipid lowering therapies, like even if we talk about statins, fibrates, niacin, ezetimibe, PCSK9 inhibitors, the clinical studies of these particular molecules has clearly shown that when it comes to LDL cholesterol, especially in case of secondary prevention, the lower is always better for longer. That is, for each millimole per liter reduction in LDL cholesterol, as I mentioned, 1 millimole per liter is 38 milligram per deciliter. So for each millimole per liter reduction in LDL cholesterol, it has been observed to show 23% relative risk benefit with respect to cardiovascular events. And this has clearly shown that, especially in case of secondary prevention, I'm talking about. And as we know, any patient who was post known case of ischemic heart disease or post acute coronary syndrome. So in such patients, the lower the LDL cholesterol is, the better. And when I'm talking about that particular category, if you look at this particular chart, they always invariably come into the very high risk group. That is, a pre-existing cardiovascular disease always come into a very high risk group of patients when we talk about treating with statins. So if we look at this particular chart, which is the European Society of Congress 2016 and 2019 guidelines with respect to treatment of dyslipidemia, we can see that as the cardiovascular risk increases, the lower should be the LDL cholesterol target. So as you can see here, moderate, high and very high risk group. And as I was saying, when you talk about secondary prevention, it is always about a very high risk group. That is a post ACS or ischemic heart disease patient. So previously the target was 70 and now the target according to ESC 2019 is 55. So with this in mind, based on the revised ESC 2019 guidelines, how patients do have controlled LDL cholesterol. So to study this, there was a observational study called the Da Vinci study, which was nothing but just a observational study of all the people who were on lipid modifying therapies, either for primary or for secondary prevention. This based in 18 countries of Europe. So a total of 5,888 patients were who were on lipid lowering therapies for either primary or secondary prevention were observed and studied. And in this, we talk about two groups. One is in all patients and one is in the very high risk group. So the shocking outcome or revelation of this study was, when you talk about all patients in general, only 27.6% of the eligible patients were actually receiving high intensity statin. And even among this 27.6, only approximately 30% of them actually were achieving the LDL cholesterol goals. So this was with respect to all patients. So when we talk about very high risk patients, so we normally expect a person who comes into a very high risk category to be 100% covered with all the essential medications and at the best possible dose. But what the study has shown hardly 37.5% of the eligible patients were actually receiving high intensity statins, and only 22% of these actually achieved the LDL cholesterol goals. So that is a very shocking revelation from an observational study of day-to-day practice. So when we talk about lipid lowering therapies, previous lipid lowering therapies and the treatment intensity, we can say that high intensity statin is defined or explained as some dose of statin which is able to reduce your LDL cholesterol by up to 50%. So this is the efficacy of high intensity statin in reducing LDL cholesterol. If that high intensity statin is combined with ezetimibe, it reduces it by 65%. And if the high intensity statin and ezetimibe is combined with the latest PCSK9 inhibitor, then the reduction becomes almost 85%. So these are the therapies we had in hand and the treatment intensity of those therapies. But what are the limitations of the current lipid lowering therapies? First point is the 80% of patients treated with statins do not achieve the LDL cholesterol target. Second point is that is due to various reasons. Second point is the patients with very high baseline LDL cholesterol usually need a combination therapy. Third point, 60% patients stop statin treatment within 1 year of initiation due to probably multiple side effects like myalgia and other constitutional symptoms. Then almost 9% there is increased risk of developing type 2 diabetes in such patients, although it has not been convincingly proven, but still there is some certain incidence of new onset diabetes in people on statins. When it comes to fibrates, it is less effective on LDL cholesterol, and the main role is actually in moderate to severe hypertriglyceridemia. When it comes to PCSK9 inhibitors, the disadvantages are the high cost, it being injectable, and also because the long-term safety is not established. Then when we talk about ezetimibe, It is less effective on LDL cholesterol and hsCRP reduction when used as monotherapy. So these are all the limitations of the current lipid lowering therapies before bempedoic acid. So coming to the bempedoic acid. This is basically a prodrug which requires activation by an enzyme in the liver. So this particular enzyme is present only in the liver and not in the muscle, and hence the muscle side effect of statins is not observed with respect to bempedoic acid. This bempedoic acid is basically a ACL inhibitor, that is ATP citrate lyase inhibitor, which is a key enzyme involved in the cholesterol biosynthesis pathway. Basically, it acts on the same pathway wherein the statins act, but at a step little higher than the statins. So this is used for the treatment of high atherosclerotic cardiovascular disease risk patients. So high risk patients who are treated with highest dose of statin, but still unable to meet the LDL targets. So as I mentioned, it is a prodrug which is activated in the liver by ACSVL1. Then it inhibits ACL, an upstream enzyme upstream of HMG-CoA reductase, which is targeted by the statins. And by this action, it upregulates LDL receptors and hence lowers LDL cholesterol. It has a half-life of 21 hours. 70% of the excretion is through kidney. And certain areas of concern or where monitoring is required is end-stage renal disease, end-stage severe hepatic impairment in patients with history of gout or with hyperuricemia, and in patients with simvastatin or pravastatin dose of more than 20 or 40 milligram. And also pregnancy and breastfeeding also requires discontinuation of this drug because it has not been optimally studied in such cases. So with all this the background, we had the CLEAR trials which were done previously with respect to bempedoic acid, wherein we had the CLEAR Harmony and CLEAR Wisdom. These two trials were basically done on people who are already on maximally tolerated statin background therapy. So this was basically cardiovascular disease or heterozygous familial hypercholesterolemia patients who are on maximally tolerated statin therapy. At the same time, there was a CLEAR Serenity or CLEAR Tranquility study, wherein even primary or secondary, both primary or secondary prevention cases were taken up. But main difference is that these were people who were intolerant to statin. So that was the Serenity and the Tranquility study. So what we see here is the Harmony and Wisdom. It basically talks about persistent hypercholesterolemia despite maximally tolerated statin therapy. And here you can see the effect of bempedoic acid on LDL cholesterol after 12 weeks. The blue compared to the gray. So there is significant reduction in LDL cholesterol in such patients. The second two studies we're talking about hypercholesterolemia in patients who are intolerant to statins. So there was it was impossible to give statins for them, and even in this group there was a significant reduction of LDL cholesterol after 12 weeks. There was a similar benefit seen with respect to reduction in hsCRP in such patients at the end of 12 weeks in all the 4 studies. So with all this background, we then came to the CLEAR Outcomes trial. Basically, this talks about bempedoic acid and cardiovascular outcomes in statin intolerant patients. This was a late-breaking clinical trial from the ACC 2023. So this is basically the CLEAR Outcomes trial is a global cardiovascular outcome study of bempedoic acid in statin intolerant patients with elevated LDL cholesterol. So what was done here is all the patients who are on primary and secondary prevention patients for cardiovascular disease with elevated cholesterol and statin intolerant. So basically they should have high cholesterol but should be statin intolerant and should be taken up for primary or secondary prevention. So all such statin intolerant patients are initially screened. Then at the second visit, they are basically taken through a 4-week run-in period with single-blind placebo drug. And at the end of the placebo drug time, on day 1, they are categorized either into bempedoic acid group, wherein they receive 180 milligram per day of bempedoic acid, or into the placebo group. So more than almost 13,970 patients were registered in this trial, and the visits for these patients were 1, 3, and 6 months, alternating phone contact and clinic visits every 3 months thereafter. So what are the primary endpoint of the study was that The effect of bempedoic acid versus placebo was studied on 4-component MACE. So when we talk about 4-component major adverse cardiovascular events, we're talking about cardiovascular death, non-fatal MI, non-fatal stroke, or coronary revascularization, or hospitalization for unstable angina. So these are the 4-component major adverse cardiovascular events. And prior to the starting of the therapy, first of all, both the arms were properly standardized. And you can see that there is no significant difference between the two groups when we talk about age, body mass index, baseline LDL cholesterol, kidney status, the comorbidity status, or the diabetic status, or the presence of other statin medications. So with respect to this, the primary and the secondary endpoints were studied. In primary, wherein we studied the 4-point MACE, and then we studied the 3-point MACE, or fatal or non-fatal MI, and coronary revascularization. And in this particular study, it showed a clinically significant benefit with respect to bempedoic acid, wherein it showed almost 13% relative risk reduction with respect to primary endpoint, and 15%, 23%, and 19% relative risk reduction with respect to the secondary endpoints. So the key primary and secondary endpoints, as I mentioned, death, MI, stroke, and coronary revascularization was the primary endpoint. And the hierarchical testing of the key secondary endpoints were the same primary endpoints, along with all-cause mortality included. So effect of trial regimens on cardiovascular events. Among statin intolerant patients, treatment with bempedoic acid was associated with a lower risk of 4-component MACE by 13%, 3-component MACE by 15%, MI by 23%, and coronary revascularization by 19%. It also showed a significant 21.7% reduction in LDL cholesterol as compared to the placebo group, and 22.2% reduction in hsCRP as compared to the placebo group. And talking about the safety analysis, with respect to serious adverse events or adverse events leading to discontinuation or myalgia, there was no significant difference in the two groups, that is the bempedoic acid and the placebo arm. There is not much significance. The only differences which were observed was with respect to hyperuricemia and gout. As you can see, hyperuricemia was seen almost 10.9% in bempedoic acid arm, whereas it was only 5.6% in the placebo arm. And the incidence of gout was 3.1 in the bempedoic acid arm and 2.1 in the placebo arm. So the conclusion of the CLEAR outcomes study was basically that bempedoic acid becomes the first ATP citrate lyase inhibitor, that is the first ACL inhibitor, and first oral non-statin to demonstrate statistically significant reduction of MACE4 events in patients with or who are at high risk of cardiovascular disease with documented statin intolerance and elevated LDL cholesterol. So bempedoic acid is an effective alternative for statin intolerant patients, as shown in the CLEAR outcomes trial. So bempedoic acid was well tolerated in a mixed population of primary and secondary prevention patients unable or unwilling to take statins. Bempedoic acid lowered LDL cholesterol by 21.7% and hsCRP by 22.2%, and along with a small increase in incidence of gout and cholelithiasis. The primary endpoint 4-component MACE was reduced by 13%, 3-component MACE by 15%, MI by 23%, and revascularization by 19%. So bempedoic acid is an effective approach to reduce major cardiovascular events in statin intolerant patients. Yeah, I think that kinds of covers the topic. Thank you. Over to you.
Thank you so much, sir. It was a wonderful presentation, to the point presentation. There are a few questions online which are there with me. I would like to ask those questions one by one.
Yeah.
So this first question just is getting refreshed. By the time it gets refreshed, you talked about ESC 2019 guidelines. So how much LDL cholesterol you see in your day-to-day practice? How much low you can go, one can go, and is it safe? Are there any neurological complications which are observed?
Yeah, good question. There is something, it's a kind of a very common question, and usually we would take, when it comes to primary prevention, we have a slightly higher threshold. When it comes to secondary prevention, then we go more aggressive. Actually, especially when we talk about young age heart attack patients and secondary prevention, we definitely try to go somewhere below 60 up to 55. Although studies say the lower the better, I think we always try to go somewhere near 60 is the target we take in. Primary prevention, obviously, the issue is it depends on the presence of other comorbidities. We need to assess the risk and benefit of such a therapy in cases of primary prevention. And I think probably in cases like heterozygous familial hypercholesterolemia or a high risk category, then probably we need to be more aggressive with respect to the LDL cholesterol target.
Very well said, sir. This next question is about my patient is she's a pregnant. She's in 8th month of her pregnancy. Is it safe to give bempedoic acid in this?
Actually, I think I mentioned that point. There have not been enough studies to prove the safety and efficacy yet with respect to bempedoic acid on. So breastfeeding and pregnant ladies, I think it is better to avoid bempedoic acid.
So next question is, I have a diabetes patient who is also hypertensive, but I am not able to control LDL cholesterol, even on rosuvastatin 40 milligram. So should I add bempedoic acid directly, or how you recommend?
Yeah, so if you basically go by the treatment guideline, I mean, usually if they're already on rosuvastatin 40 milligram, I think there is an option always of adding even ezetimibe initially. And not to forget the combination, triple combination also has been tried when we talk about rosuvastatin and ezetimibe and bempedoic acid. So I think we can go in sequentially with maximal tolerated dose. So ezetimibe is definitely an option, and then followed by bempedoic acid, or both together.
Okay, sir.
So there have been trials of 180 bar 10 milligram combinations where we have a combination of bempedoic acid along with ezetimibe.
So next question is about my patients who is a diabetes patient. So as you said in one of your slide that 9 to 13% of the patients with statin treatments are risk of developing new onset of diabetes. So is it any bempedoic acid, any data that it is safe in diabetes
Yes,
patients?
good question. There has been a study which tried to evaluate the risk of new onset diabetes in patients on bempedoic acid. I'm not able to recollect the name of the study, but it had shown that definitely there is no increased risk of diabetes, new onset diabetes in patients on bempedoic acid.
So this is my question from my side. Since many Indians are having risk of diabetes, they are having also hypertension, they are smoking, lifestyle more, and it is always said that Indians are at high risk of developing cardiovascular diseases. So coming to the LDL cholesterol, and somebody is talking about triglycerides. So what is important to balance? LDL cholesterol you will give importance or triglycerides, and how LDL cholesterol is important if it is important?
Yeah, so with respect to that, as long I mean a triglyceride of more than 400 definitely warranties the use of fibrates separately. But if not so, then always the primary target is LDL cholesterol with statins. And then if you're not able to achieve the target, then we go in for fibrates for triglycerides.
Sir, sometimes statin intolerance is misunderstood. So, any particular thing you would like to recommend for the audience so that statin intolerance can be easily recognized and then treatment of with bempedoic acid can easily be given.
Yeah, definitely. Many a times the way symptoms of statin intolerance is very vague. It produces some kind of body pains, muscle pains, and not very easily diagnosed. Sometimes what we do is all patients who are on high dose statin therapies, we make it a point to repeat LFT, CK-CKMB in the follow-up of such patients. I think by doing so, you're kind of prepared to catch hold of such cases wherein you find intolerance.
Thank you, sir. It was indeed a pleasure having you on this evening talking about clear outcomes trial and CLEARTalk. So, any final remarks and concluding remarks or take-home message for our delegates?
Yeah. So basically, as I was mentioning, there are two scenarios, which is primary prevention and secondary prevention. Secondary prevention, we need to go more aggressive. Primary prevention, based on the presence of other comorbidities, such as even a history of strong family history of heart disease or other comorbidities, based on the number of such risk factors or the amount of risk, our aggressiveness should depend on the comorbidities in case of primary prevention.
Thank you, sir. It was indeed insight and indeed a great pleasure having you on this evening talking about clear outcomes trial and bempedoic acid. So I would like to thank from Zydus Life Sciences point of view to all our delegates for being interactive and making this CLEARTalk successful. I would like to, it's my honor to thank Dr. Rahul Patil sir for being with us on today evening and giving and clearing all our doubts on bempedoic acid. Thank you so much, sir, for being with us. And I hope the expertise and experience what Rahul sir has shared will definitely help all our delegates to treat dyslipidemia patients in day-to-day life. Thank you so much, sir, for being with us once again. Thanks a lot. Have a nice day. Good night. Thank you so much.